Okay, hello everyone, and welcome to KITE's Research Round. It's my great pleasure to introduce our speaker today, Professor Alex Mariakakis. Professor Mariakakis is an assistant professor in the Department of Computer Science at U of T, and he's also an affiliate scientist at KITE. He runs the Computational Health and Interaction (CHI) lab, which leverages ubiquitous and emergent technologies to address problems related to people's health and well-being. His work has garnered multiple Best Paper awards at ACM venues such as KI and Compass, and significant attention from media outlets ranging from the BBC to National Geographic. Dr. Mariakakis received his PhD from the School of Computer Science and Engineering at the University of Washington, where as a student, he received the National Science Foundation Graduate Research Fellowship, the Quantum Innovation Fellowship, and the Gaetano Borriello Outstanding Student Award at UBCOM 2018. So please join me in a virtual round of applause to welcome Professor Alex Mariakakis.
Hey
Alex, the
everyone,
floor is yours.
thank you. And I can't see you all, but thank you for joining, I guess, on this intermediate holiday break. So today I'm just going to give a wide overview of the research that I'm doing in my group. And to start off this presentation, I like to ask a question. Normally I make this a little interactive, but I'll just leave this as a thought exercise for everyone. Very charged question to start off with presentation with. When did you last see your doctor? And there could be a lot of things that might be going through your mind. When was the last time you might have had a medical episode? How convenient is it for you to get to your doctor? All these sorts of questions. So, to give you an example of what a timeline could look like, bearing in mind that there's no such thing as an ideal timeline, a classic example might look something like this. Some of us might have access to a clinician that we meet with or a family doctor that we meet with on an annual basis. And maybe we have these situations like a broken foot or some sort of medical emergency once in a while. And we have these, and the reason why I want to put this timeline up here is that there's a couple of different gaps in this timeline, right? So one of them is the gaps in time, right? The fact that even though we have these annual checkups and we might have these episodes, there's these breaks in between where we don't know exactly what's going on with our health, right? And even within these gaps, or even if we ignore them, there's also gaps in what we know about our health, right? So let's say, for example, I go in for my annual checkup and they're checking, very basic information about my heart, my lungs. They do a physical. They probably aren't going to do a full blood workup unless they actually suspect that there's something wrong with my blood. And then, down the road, if I go to the doctor because I have a broken foot, they aren't going to go through the same battery of tests over and over again. They aren't going to check my heart. They aren't going to check my lungs. They aren't going to do blood work, hopefully. That's costly. They're just going to be looking at my foot. So with these kinds of timelines, I would argue that no matter, how often you go see your doctor, there's going to be these gaps. And these gaps exist for a variety of different reasons. So, for example, I'm from the United States, and one of the big barriers that people point to is cost. So, I have this statistic here that says for the average uninsured American, they pay roughly $160 for each primary care visit. Now, we're in Canada, but that doesn't mean that we're immune to challenges associated with healthcare. And one of the classic challenges that people like to point to here is the wait times, right? Even if I know that there's something wrong with my health and I want to go see a doctor, it can take a lot of time for me to actually get to see them face to face during the consultation. I have to wait a few days, put myself on a list at a walk-in clinic, for example, and then wait a while. Now let's imagine that we lived in a fairy tale world where we were able to remove all of the barriers associated with us as patients to go see doctors and get information about our health. We also have to think about the flip side of the coin, right? Physicians are experiencing very high burnout right now. They can't see every single patient constantly. It takes a lot of time to document all of these cases. So, and just even the number of physicians that we have right now, particularly in Ontario, does not meet the demand of the patients that we have. So, if we were to lower the barriers of access for patients, we also have to think about physicians as well. Now, ultimately, and I'm sure there's other barriers that you can think about when you're thinking about our healthcare systems. Ultimately, what we're left with is a reactive inpatient healthcare system, one that reacts to acute events that happen. And what my research attempts to do is to create a proactive outpatient healthcare scenario. So rather than having to utilize clinical resources for these very costly and expensive incidents, can we rely on more low burden and accessible health technologies to be able to monitor people's health outside of these settings? So what my research group does is that we take advantage of ubiquitous devices. So in case you haven't seen that word ubiquitous, it just means all around us, pervasive, terms like that. So some examples might include smartphones, smartwatches, smart rings, and you can also think of emerging technologies like textiles and other wearables, for example. And my group takes advantage of the sensors on these devices, and I use the term sensors broadly construed. So it could be anything from audio and motion to location to light to cameras, etc. And then we apply machine learning, computer vision, digital signal processing to extract health indicators. And these indicators I like to think of in three categories. The first might be contextual indicators, so things like mood and sociability. Is this someone who goes out and tries to be social with other people, or are they staying at home static, maybe less prone to physical activity? And on that note, behavior. So, physical activity and sleep are some classic examples that we now see in wearable devices that are being used as health indicators. And then there's also physiological data, things like heart rate, cough rate, etc. Now, just getting these individual markers on its own is great, but where the real power comes is from combining this data together to relate to high level health outcomes. For example, respiratory disease, aging, or psychological well being. Now, it's at this point, depending on the audience, and I think a group like KITE and UHN is a good audience to make this disclaimer. I want to be very clear that today I'm not trying to argue that technology should be replacing doctors. We still want to keep doctors in the loop in all of the healthcare decision making that we're going to have. I'm not going to say, hey, we're going to build a smartwatch app that's going to diagnose people with cancer, for example. But that being said, I think that there's a role for these technologies to augment the capabilities of doctors. And because of that, I think that there's multiple roles that technologies can play. So a lot of people, at least in my circle, when I hear them talk about mobile health, they think about it like diagnostic screening. This is kind of one of the holy grails to be able to say that we can detect a condition earlier than a doctor can. And I think there is potential for technologies to be able to do that. But I think there's also other opportunities. So, for example, if I know that someone already has been diagnosed with a condition, rather than keeping them in the hospital or asking them to come into the hospital every 3 months for a checkup, can we give them some tools that they can use at home as an outpatient and to monitor their health over a longer period of time? And if we discover that that data looks off, then we can bring them into a clinic, bring the doctor back into play, and then have them discuss their health together. And then health isn't just about diseases, right? There's all sorts of different health topics that people care about on a day-to-day basis that are related to health, but doesn't necessarily need to be associated with the hospital. So also thinking about health in terms of general wellness, right? Physical activity, menstrual health, these kinds of topics don't have to necessarily involve a diagnosis. Now, because a lot of these different applications involve not just doctors, but also ordinary people as active players in their own healthcare, I think it's really important that we think about the human-centered design component. And the classic example I like to borrow from a colleague has to do with a bathroom scale. So this, I would argue, is one of the most basic ubiquitous technologies we have for healthcare. You stand on a scale, it gives you a weight, and it has a very basic interface, right? It has two numbers, at least on this screen. Now, imagine I step on this scale on a Monday and it tells me I weigh 60 kilograms. And then I step on it the following day and it says I weigh 61 kilograms. What does that mean about my health? Is my weight going up 1 kilogram a day? Should I start worrying about my massive weight gain? Or is there some other factor at play? Maybe I was, dehydrated the first day. Maybe I forgot that I was wearing different clothing and one set was heavier than the other. Maybe I had a big meal. Maybe it's just sensor error. The device is off. All these are very complicated questions or simple questions that complicate the information gathering process for a very basic interface. And people can jump to very radical conclusions about their healthcare based on just that single number. So what happens if I start saying, hey, we can build these cool technologies that can measure blood pressure, that can examine a skin lesion and detect whether it might be malignant or benign, right? So you can imagine the hypochondria that might come up from these kinds of applications. So with that in mind, and a very important component of my research isn't just building these technologies, but also thinking about how people consume this data and interact with the data that they're collecting. So as Babak already mentioned, my group is called the Computational Health and Interaction Lab, and we use ubiquitous and emergent technologies to address problems related to people's health and well-being. And I break up my research agenda into three areas. The first has to do with momentary health assessments. So this is the idea of taking a device out from your pocket, for example, interacting with it in a very controlled manner, and then getting some sort of health measurement. The second has to do with continuous health sensing. So if you've ever heard of terms like passive monitoring, the idea of using a smartwatch, for example, to monitor heart rate throughout the day, or even coming up with new biomarkers using passively collected data, that would fall in this category. And then the third category has to do with interactive design. This idea of the fact that people need to see the data, be able to interact with the data. So how do we build these interfaces in a way that's going to be acceptable to them? So my goal in this presentation is to give you a breadth of the research in these three categories. I'm first going to tell you about one project that has to do with the sensing aspect, so more on the data science machine learning side. One that's going to be more on the interactive side of thinking about how people interact with the technologies. And then the third project is going to put those ideas together to show why I think these two ideas are going to be really important for acceptable technologies. So with that in mind, the first project I'll talk about has to do with using earbuds, oddly enough, for acoustic cardiac sensing. And I'll, of course, get to how we get to that idea. So many of you have probably seen a screen like this, whether it's on an Oura Ring or a Fitbit device. And this is like a smartphone screen that you would see. And you would notice that it has very basic clinical vital signs, right? And in fact, if you're familiar with clinical signs, you would know that there are four classical vital signs: temperature, heart rate, respiratory rate, and blood pressure. Now, if you take the list I have on the right side and compare it to what you see on the screen on the left side, or at least what you might imagine seeing on these kinds of screens, you would notice that for the most part, many of these devices only have three of the four vital signs. They do have temperature, we do have heart rate, we do have respiratory rate, but blood pressure has kind of been this holy grail of digital health technologies. It's something that we don't really have on smartwatches and wearables. So it's something that people are really keen on getting because it's such an important measure. Now, that's not to say that we can't measure blood pressure in people's homes, right? So, for example, we have blood pressure cuffs. That's considered the gold standard for blood pressure estimation. And there are models of blood pressure cuffs that can be used at home, but they can only be used occasionally. And it's quite a time-consuming procedure, right? You have to sit down in your chair, wrap the cuff around you, sit there, and get the measurement. It's not something you can really do out in public throughout the day in an office. It's something that people normally do at home, and for the most part, not daily unless they have some sort of known condition ahead of time. Now, because of this, there's been a lot of work in the ubiquitous computing research community to use commodity devices like smartphones and smartwatches to be able to get estimates of blood pressure. There is a slight benefit to the smartwatch-based solutions because it's a wearable device that works continuously, but the smartphone solutions still have the convenience of using a device that we carry with us on a regular basis. Now, to give you a rough idea about how these latter two categories work, most of them are built on using photoplethysmography, which I might imagine many of you in the audience already know about, but I'll give a quick review of what this term is for those of you who don't. So photoplethysmography is basically a light-based measurement of pulse activity throughout our body. So the basic idea is that you shine the light into a finger, earlobe, the wrist, and then you measure how much light gets reflected back into a photodetector. In fact, the example I like to give for the phone-based example is if I were to take my phone that you can see on the camera right now here, I could turn on the flash of my camera and I could cover it with my finger. And right now, it just looks like my finger is glowing red. But if it turns out that if you actually record my fingertip with a camera and I were keeping my finger very still, you would notice very subtle changes in the amount of light that's getting reflected back into the camera. And that's because as blood flows in and out of the fingertip or the wrist or whatever part is being measured, there's different amounts of blood that are absorbing and reflecting the light, and therefore you get a different amount of light that gets reflected back into the photosensor. And what this ultimately produces is a waveform that reflects how the pulse is moving through the body. So you could get heart rate, for example, very easily. But it turns out that you can use a category of techniques called pulse wave analysis, or PWA for short, that looks at the morphology of this waveform. So looking at the ratio of peaks to valleys, the slopes, the notches in the curve, etc., and then applying machine learning to this shape to infer blood pressure. So that's how these techniques work at a very high level. But because it's a light-based measurement, there's one big limitation I would argue with these techniques, and that's the confound of skin tone. So the amount of light that gets reflected back to the sensor using this technique is very dependent on skin tone. And there's been a lot of research that's commented on biases in heart rate monitors and Fitbit, for example, because of skin tone. The same thing applies with blood pressure as well. So in my research, I've been thinking about other ways that we could get this kind of cardiac information for blood pressure estimation. And it turns out that heart sounds that you might get from a stethoscope, for example, contain very rich information about cardiac function. There's a reason why people do auscultation very often during regular checkups. But if I were to give us an ordinary person a digital stethoscope and say, record your heart sounds, it's not necessarily the easiest task for a person to do. So one of the questions we've been asking is there a more convenient way for us to get heart sounds? And then secondly, can we use these sounds to estimate blood pressure? Can we take that waveform that we would get from the microphone and convert it to something that we would do with pulse wave analysis? And it turns out that heart sounds aren't just contained in the heart. They travel throughout the body. And in fact, they travel throughout the body to the point where they get to our ear canal. And I'll explain exactly how in a little bit. But if you don't believe me, think about the last time you went on a very vigorous exercise. So maybe you, I don't know, ran a marathon, walked up the stairs, or something in between. You might remember a phenomena where you thought to yourself, man, I feel like I can hear my heartbeat. I can hear my heart pounding. It's so strong. That's the phenomenon that we're relying on. And it turns out you don't just need to do strenuous physical activity to detect these heart sounds. We can actually detect them using active noise canceling earbuds, just like the ones that you would have from Google, for example. Like I have these Google Pods right here. The reason why we can do this is that active noise canceling earbuds have a few different sensors in them to do active noise cancellation. So the point of active noise cancellation is that there's some sort of ambient environmental noise, so car horns, crowds in the background, and these earbuds are designed to play basically anti-noise, the opposite of what it's hearing, to try to cancel it out so we can hear whatever we're listening to, our podcasts, our music, or whatever. In order to do this, active noise canceling earbuds have two microphones. They have an external microphone to hear the ambient sound, and then an inner microphone to make sure that that feedback loop to play the anti-noise is actually working. So what this means is that we have a microphone that we can place inside the ear canal that can hear these very subtle heart sounds so that we don't have to ask people to put a digital stethoscope on their heart. We can actually get a recording of these heart sounds throughout the day. Now, and I just remember that I didn't share my screen with audio, but that will be okay for this presentation because it's a very brief recording. What I'm showing here on these four different graphs, or we'll start off with the first one, are the audio waveforms that we've recorded from a digital stethoscope that was placed right at the heart, and the raw earbud recording that was taken at the same time. And it suffices to say that if you're to look at the waveform on the bottom, the raw earbud audio that we're getting is very noisy. So it's not like we could just take this audio recording and do our analysis right off the bat. There's a lot of noise that we have to deal with. So, and the sound is playing in my background, so I'm going to pause it there. So one of the projects that we worked on called EarSteth took this noisy audio and used a machine learning model. If you're familiar with concepts like audio super resolution, for example, we basically take a model that takes in audio and outputs audio, and we set it up to try to clean up the audio in a way that emphasizes the heart sounds so that the recording we got from the earbud sounded comparable to a recording that we would get from a digital stethoscope. And you can see this output here on the bottom row, where now you can see these very precise peaks corresponding to the S1 and S2 sounds that we didn't necessarily see in the raw earbud. Now, there's a lot of technical things I could get into about what this is doing and what it's not doing, because some people might say this is just removing static. Is it actually preserving the heart sounds? So a big part of this research was actually making sure that we are preserving the characteristics of the S1 and S2 sounds of the heart itself, but you can read the paper for more details. And on that note, one of the challenges I actually had with this paper was it was actually hard for us to get this paper published. There was a lot of questions about what the actual mechanism of the heart sound production was. Are we getting direct sound transduction? Like, are we getting the sound wave traveling from the heart to the ear? Or is there something else going on? Is the pulse wave actually traveling along the arterial tree and causing something near the ear canal that is producing the sound? So eventually we had to answer this question for ourselves so that we knew why this was working. And in order to do this, it's really hard to build a biomechanical model that precisely explains this procedure. So what we did instead was that we looked at explanations from prior work, and then we did a timing analysis to see if those explanations lined up with the signals that we were seeing. So what we did was we took a digital stethoscope recording as kind of our reference standard. And then we applied two digital filters onto the earbud audio. One that preserved lower frequencies, so basically bass tones, specifically at 20 hertz, and then one that preserved higher tones in the 35 to 50 hertz regions. It took a little bit of playing around to pick those numbers, but basically low bass tones and higher tones. And then what we did was that we looked at these signals simultaneously. And we saw these different peaks and valleys in the different signals, which led us to this question. Knowing the distance from the heart to the ear, do we see content in the earbud audio that corresponds to the speed of some sort of phenomena? In other words, if I took the time it takes from the pulse to travel from one place to the other, does this line up with an explanation that we saw in prior work? So one of those explanations was compressive heart sound wave. So in other words, the speed of sound through a body, essentially. And we found that the higher frequencies matched to this explanation. When we filtered the signal accordingly here, the timing between the two peaks was very close, corresponding to the speed of sound. But we also saw that when we did the low pass filter on the signal, we saw that the timing of the signal roughly corresponded to the pulse wave. So what's happening is that as the pulse physically travels through the body, it eventually travels near the ear. And then what happens is that the arteries near the ear, they dilate and then they constrict. And through that process, it's very subtly deforming the ear canal. And that ear canal deformation is basically producing a pressure change inside the ear canal, and that gets detected as a sound. So we're one of the first groups to be able to identify the fact that both of these phenomena are happening together to produce the heart sounds that we're recording, and others are also recording in earbuds for this technology. But we haven't stopped there. That's just explaining the working principle and the fact that we have heart sounds. Remember that I talked about blood pressure. So when we looked at the low frequency, the low pass filtered audio, the focusing on the lower frequencies, we actually looked at that shape of that curve, like you see at the top row here. And it actually turned out that the shape of that curve looked very similar to other waveforms we had looked at in the past. So what I'm showing in this example is that we have different columns here associated with different participants, so basically different pulses. The top row corresponds to the low pass filtered audio that I showed earlier. And then the next three rows are not just the PPG, that light-based measurement I showed earlier, but the second derivative or the acceleration of that waveform. And then we also have one of the pulse wave, so it's a similar kind of measurement here. And when we looked at these waveforms, we actually noticed that they were very similar. The peaks lined up with the peaks, the troughs lined up with the troughs. So ultimately, what we were able to do is that we built a project. It's in submission, and we call this project Arterial because we can use puns now. We have the word ear here. And we're able to show that we could take the waveform we were getting from the low-pass filtered earbud signal, and do some machine learning, specifically some deep learning signal reconstruction, along with some double integration to eventually get both the acceleration of the pulse wave as well as the original pulse waveform representing cardiac function. Having that signal, we can now apply those pulse wave analysis techniques I mentioned earlier. So looking at the peaks and valleys, the distance between different fiducial points in the signal to estimate blood pressure. So I'm not going to go through the table of metrics, but this just goes to show all the different kinds of morphological features that people are trying to use to estimate blood pressure. So we have a system that we've been building called Pulseer that uses that reconstructed pulse waveform from an earbud to estimate blood pressure. And this work is still in progress, but to give you an idea of how far along we are right now, we have a system that is able to estimate systolic blood pressure with an accuracy of 7.5 millimeters of mercury and a diastolic blood pressure with an average of 4.6. So if you go to the American Heart Association, for example, their criteria of what passes for a good blood pressure cuff is 5 millimeters of mercury. So we're good for diastolic, not for systolic. But what I will point out is that we took the exact same techniques and we applied them to finger PPG and earlobe PPG and used them. And we basically got very comparable results. So we're basically on par with comparable techniques using things like PPG ear clips or smartwatches. So I'm going to continue on to switch gears and talk about a different project. And I think I'll leave questions at the end because we're in a virtual environment. So that talks about a sensing application. I'm now going to talk about a design consideration and specifically some work we've been doing at using chatbots for patient pre-consultation. So it goes without saying, hopefully for you all, that patient-physician interactions are a very important aspect of healthcare. Doctors don't know how to treat us unless we tell them what's wrong with us, and vice versa. We need to be able to voice our concerns when we're patients so that doctors can give us the best healthcare possible. But there's a lot of barriers to having very well-organized patient-physician interactions. So from the patient side, patients are often sick and worried, so communicating clearly isn't always necessarily a top priority. There could be perceived power dynamics where people may feel uncomfortable sharing information with a doctor, or they might let the doctor lead the questioning and not feel comfortable sharing their own thoughts that they may think might be related. And from the doctor's side, I already mentioned they have to deal with long wait times, data entry demands, and documentation burdens that just make it very difficult for them to spend a lot of time to really hear people's concerns. So ultimately, what this leads to, obviously, is a very strained interaction, something that could be made better through many different mechanisms. And to this end, there are some mechanisms that are already in place to try to foster better patient-physician communication. And one of them is pre-consultation. The idea of before we go have a consultation with a doctor, the patient shares some health information either through a questionnaire or an intake nurse so that they get a rough understanding of the patient's chief medical complaints and their prior medical history. That way, when the doctor actually meets with the patient, they don't have to go through all that kind of basic form information ahead of time. They can get to the root of the problem and talk about the chief medical concern. And a key thing I want to emphasize about pre-consultation is that it doesn't involve diagnosis. Whether it's done through a questionnaire or an intake nurse, the role of these players is not to diagnose the patient, it's simply to collect information so that the doctor can make a more efficient judgment. Now, there are trade-offs with these two modes of pre-consultation, the questionnaire and the intake nurse. A questionnaire, something like, say, a digital form or a digital survey, you might do a Qualtrics or REDCap, for example, can be highly scalable and very cost efficient, easy to do. But I don't know about you all, I hate filling out forms, especially when they're very long. So they tend to have lower engagement and lower response quality. I may not feel like I want to type out all the medical concerns I have, so I'm going to keep it very terse and only use a couple words because I know eventually I'm going to talk with a doctor. On the other side, intake nurses have the opposite kinds of trade-offs. It's really hard to hire trained expert staff to do intake on a regular basis, so it's not necessarily the most cost efficient or scalable solution. But intake nurses can be engaging. They can have a back and forth conversation. They can be, talk about the weather with us and have that nice chit chat before they're asking me about my chief medical complaints. So the question we've been asking my group is, can we get some sort of solution that merges the trade-offs, get the best of both worlds? Something that's scalable and cost efficient, and also having something that's highly engaging and gets us high response quality. And I've already kind of beaten myself to the punch about the solution. We've been looking at using chatbots and LLMs for this purpose. So we actually have LLMs for two different purposes in this context. One is a chatbot interface that's designed to replace that interfacing component, talking with the patient to gather the information about the chief medical complaints and the patient history. But if we just had that component, what we would be left with is a big, long summary that doctors would have to read in order to know how to actually go through their consultation. And we knew that wasn't going to solve the problem because that's a very time-consuming task to go through a long transcript. So we've also been working on building a summary interface, so a separate LLM that takes that chatbot transcript and distills the information into a format that could go into the EHR, can go into the clinical notes right before the physician talks with the patient. Now, with this kind of ecosystem, there's actually a lot of different research questions that one could ask. We could ask, how should this chatbot behave? Should it be super professional? Should it be very casual? And how should the summary be formatted? Should it be very long? Should it be very condensed, bullet points, et cetera, et cetera? We also need to ask the question, is the LLM capable of getting high quality information? Because that's something that we would ideally trust an expert intake nurse to be able to do. Are they able to ask the right questions to be able to get the right information out of people? And then, of course, what are the benefits of the solution, right? How is the agent ultimately able to help patients voice their concerns? How is it able to help physicians know exactly what kinds of questions to ask and to document everything? Now, I won't be able to go through all of these research questions, obviously. I'm going to focus on these latter three for the sake of time. So what we did in order to actually to answer these questions was that we built a chatbot and we deployed it into a local walk-in clinic in Davisville, actually, in Toronto. And we specifically chose a walk-in clinic in this case because it's a scenario where patients don't have a medical history, the physicians don't know the patients ahead of time, and the patients present with diverse health concerns. And these are kind of the ideal scenario where pre-consultation can be particularly useful. And through conversations with physicians and actually some of our own prior work, we came up with a prompt that looked like the following. It had a set of instructions that told the chatbot how it should behave. I'm not going to read through all of these things, but as an example, one of the things that we wanted to make sure the chatbot didn't do was ask double-barreled questions. So two questions within the same turn, which will require people to answer two questions at the same time. We also gave it a list of questions that it should ask. So it's not like we're asking the chatbot to come up with questions on the fly. We gave it a list of questions and we said, you should be able to answer all these questions by the end of the conversation, but you are allowed to ask follow-up questions. You can skip the questions. You can shuffle the questions around if needed. I will mention that we built this using GPT-4. One of the questions I very often get is why we didn't use something like MedPalm or something that's health specific. I'll leave that as a question at the end of the talk if you want to have a kind of easy layup question, but I'll just say that we use GPT-4 for now. So when we deployed this chatbot, we got a lot of transcripts back. We had a lot of people interact with it in various ways. And we had this first question of like, how do we know that this chatbot was actually successful? How do we know that it got good information from the patients? Well, one thing we could have said is that the longer the transcripts were, the more words that we saw, then the better the engagement, right? People type more, that's usually a good thing. But that wasn't a great metric because it depends on the case complexity, right? The more complicated someone has, more complicated medical history someone has, for example, the more words they're probably going to type. That doesn't mean the chatbot is doing a better job per se. We could have asked the question, is the chatbot getting the most complete information possible? Is the physician ultimately getting all of the information that they need in order to have a good visit? And that sounds like a good metric to use, but it's really unclear what information would actually be relevant. You don't really know until you actually have the consultation whether the information is going to be relevant during a pre-consultation stage. Like maybe you don't know that someone's daily alcohol consumption or family history actually explains their fever or their cold. And even during the consultation, just because it's not relevant for that visit doesn't necessarily mean it's not going to be relevant for a future visit. So this was a really hard one for us to define. Finally, we could just say, was the visit successful or not, right? Was everyone happy when it was all said and done? But again, this depends on case complexity, how much time the physician had during the visit. It wasn't really a great metric. So we need to come up with a different solution for measuring information quality. Excuse me. And for that, we turn to actually a technique or a concept from linguistics called Grice's maxims. So these are linguistic principles that guide effective communication for just normal human-to-human conversation, nothing to do with machines or LLMs. These are the four Grice's maxims. They're manner, quantity, quality, and relation. Rather than defining these, I'm just going to show the versions that we adapted because we need to morph these a little bit to work for our particular research questions for this context. So the four concepts that we used were clarity, depth, informativeness, and relevance. And you can see the definitions there. Hopefully, for the most part, they're self-explanatory. So to give you an example of how we use these Grice's maxims to analyze our conversation transcripts, I'm going to show you an actual example from our study without any, patient name or information. So in one example, the chatbot asked, "Are you currently taking any medications?" This also includes over-the-counter medications and herbal medications. And the patient said, "Yes, the pill." Now, if I were to take those Grice's maxims and apply them to this conversation turn, the question and answer, I would say that it's informative. I know that the person's taking a medication, and it's relevant because it's a medication again, but it's not really clear and it's not really deep, right? What is the pill that they're talking about in this context? So what we would say ultimately is that this is not a satisfactory conversation turn. We need more information in order to get a complete answer to this question. The chatbot in this case was actually smart enough to ask, does this mean the oral contraceptive pill because of earlier context in the conversation? And the patient said yes. So while the answer yes in itself, that one word, is not necessarily the most informative thing, when we combine it with the question, we're ultimately left with a total response that is clear, deep, informative, and relevant. And when we put all these together, we say we have a satisfactory answer to the question, and then we move on. So we applied this kind of coding scheme. We call this qualitative coding in human-computer interaction. We applied this to all the transcripts we gathered from a walk-in clinic, and then we compared a few different conditions. And those conditions, I'll just pop up on the screen here, are as follows. We had our LLM chatbot as one of the different ways we did pre-consultation. We did a Wizard of Oz study where people thought they were conversing with a chatbot, but they were actually talking to a medical resident who was typing into a chat interface as if they were a chatbot. And we also had a questionnaire, so basically static questions that didn't change whatsoever. And what we found was that the dynamic agents, the Wizard of Oz and the LLM, were actually better at getting satisfactory responses to the initial question. So when it asked one of the questions from the list I showed earlier, just the initial responses that I got were generally better than in the questionnaire condition. And this was because the dynamic agents were able to skip questions that were uninteresting or irrelevant. They were able to reword the questions to make them more clear. And they also reordered the questions in different situations. The other thing that we found was that the follow-up questions asked by both the humans and the dynamic agents were able to help gather even more useful information. Unsurprisingly, the Wizard of Oz, the intake nurse who pretended that they were a chatbot, were able to ask more useful follow-up questions, but we found that the LLM was able to ask some useful ones too. So as an example here, we have a situation where the chatbot said, "Understood. Do you have a personal or family history of mental health conditions?" The person simply says yes. So the LLM followed up and said, "Could you please provide a bit more detail? Your privacy is respected, and this information helps us in providing complete care for you." And then the person followed up and said depression, anxiety, and bipolar disorder. So by conveying the fact that, hey, this is a really important thing for me to know about, I would appreciate if you could be, more clear in your response. The chatbot was able to solicit a more thorough answer from the patient, which would hopefully ultimately improve the actual consultation itself. So this is a quantitative approach to looking at how well the chatbot worked, but we also did some qualitative analysis. We asked clinicians and physicians to say, hey, well, why is this useful for you relative to other pre-consultation? So one of the benefits that was really cool to see from the patient side was the idea of confidential disclosure. So I mentioned earlier that sometimes patients might feel uncomfortable sharing information to a person face to face. So like alcohol consumption, for example. But we found that some people actually felt more comfortable sharing this information with the chatbot. And there is, of course, an ethical discussion about, what are the implications of people sharing private information like that to a chatbot. But it was an interesting observation to see. And I'll point out this quote here where someone said, I'm not bothered by putting things out on the internet, or maybe it's just my age showing, but I would prefer this over talking openly in front of like a room full of people. Now, of course, consultation is not a room full of people, and neither is pre-consultation, but it's that idea of having a buffer between those individuals where I could share that information and then later discuss it with a doctor only if it's necessary. For physicians, one of the useful features that we found about this process is that having this chatbot anchors the conversation. So we have this scenario that one physician pointed out where a patient came in and talked about something, and then 10 minutes later they said, well, actually, the real reason I'm here is for some other reason. So these patients, they would sometimes come in with multiple health concerns, and they would just start randomly talking about one or the other, and they didn't actually talk about the one that was really important. So if a doctor has an agenda ahead of time and they know that these are the things that have to be addressed, they're able to guide the conversation, steer it to make sure they're making the best use of their time. By the way, if you're interested in using this chatbot, you're welcome to play around with a demo prototype that we have here. Of course, we don't have, please don't put any personal information if you're going to play around with this. This is just for research purposes. But I put this up here to show both the chat interface and an example of the summary because I didn't really have a lot of time to talk about it. But this is something we've been actively exploring, the idea of having a narrative summary at the top and having something that's more of a tabular format or bullet points that someone can more easily copy into their EMR or their health system. So those are two different projects I've talked about so far. One on the sensing side, one that's more on the user-centered design side. For the last project I want to talk about, I want to merge those together and talk about why it's important to think about design when talking about technology. And I'll specifically talk about this in the context of the menstrual health research that we've been doing in my group. So, why menstrual health? Why is this a topic that's so important? Well, many people consider it a vital sign, right? It's one of those things that isn't just a medical condition, like I mentioned earlier. It's a facet of health that roughly half, if not more than half, of the entire population cares about on a regular basis. And because menstrual health is such an important topic to many people, there's thousands of apps that are out there. In fact, there's over 200 million downloads of menstrual health apps in 2019 alone. But many people are often left dissatisfied with these apps. And there's many reasons why people are dissatisfied with the current standard of menstrual tracking. One is that it's not just about knowing when someone is next going to menstruate. There's all sorts of reasons that people care about their menstrual health. So yes, people do ask this question of when is my next period going to be? And that's why a lot of people turn to these apps. But there's these other questions. When do I typically get mood swings? Is my menstrual cycle normal? What is going on with my body in general? Now, you'll notice with that third question, I put an asterisk next to the question, is my menstrual cycle normal? And that's because many scholars argue there's no such thing as a normal menstrual cycle due to interpersonal biological differences. And that leads to the second challenge. There's no such thing as a typical menstrual cycle. So, yes, if you're to take a generic population of people who menstruate and you look at the average cycle length that they experience, you would find something that follows with conventional wisdom, an average of 29 days plus or minus 3 days. But if you're to take or look at the spread of those of the ranges that were measured for those individuals, you would find that there's massive variance both within and across individuals. For example, the range of in this study, at least in 2004, the range of cycle lengths experienced across all the participants went as low as 21 days and as high as 35 days. That's neat. That's practically triple the range that you see in the average statistic there. If you look within an individual, you would find that that 46% of individuals experience a range of cycle lengths that is longer than 7 days, or a difference than 7 days. So I might have, someone might have a menstrual cycle that's 21 days on one month and then 28 days the next. So that's a massive variance that if you just assume that everyone has a consistent menstrual cycle, just doesn't work. And that's why a lot of people are often left dissatisfied. And this brings me to a third challenge associated with many menstrual tracker apps, which is self-reported data isn't enough. A lot of these apps rely on very basic self-reported information, things like dates of menstruation, amount of bleeding, severity of cramps, and mood swings. And based off that data alone, it's really hard for these kinds of apps to project when someone is next going to menstruate, especially because these baselines can, diverge for people across individuals and over time as well. So with my research group, we've been asking this question: what should go into an accurate and insightful menstrual health tracker? And we break this up into a whole bunch of follow-up questions again. What are the limits of current menstrual health resources? I kind of talked about some of those earlier. If we're to take advantage of multimodal sensor data, how can we use this data to make menstrual tracking more accurate and more insightful? And also, how can we help people overcome the challenges associated with using or gathering this kind of data? And again, for the sake of time, I'm only going to focus on these middle set of questions. So when we embarked on this journey, this idea of building an accurate and insightful menstrual health tracker, very early on, the PhD student who was working with me and her supervisor, we all speculated together that access to data was the main burden. If we just give people a whole bunch of data and a whole bunch of devices, people are going to learn so much about their menstrual health and it's going to be great. We'll be able to build these great algorithms and it's going to be cool. So we conducted a 3-month study where we asked people to collect various forms of data. We asked them to kind of fill out a standard self-report survey like they would with a normal menstrual tracker. So they reported when they menstruated, the symptoms they were experiencing, diet, these sorts of things. We also gave them a Fitbit because we said, hey, Fitbit is a thing that can measure all sorts of useful physiological measurements, heart rate, sleep, activity. That's got to be useful, right? And people know how to work with this data. We also used a Mira hormone analyzer. So this is something a little less conventional. This is a urinalysis dipstick that interfaces with a digital device that can actually measure the quantity of various hormones, things like progesterone and E3G or estrogen, LH3 and estrogen. I have the hormones there. And it's designed for home use, so people can use it on a daily basis. Normally, they use it for if they're trying to seek pregnancy, but this can also be used to measure hormones that are related to menstrual health. And we thought if we give people access to hormone data, this is really going to open their eyes to various aspects of their menstrual health. And then as a final one, because we were super ambitious, we also looked at glucose because there's a lot of literature that talked about the relationships between glucose and other hormones. And we said, wow, if we could give people glucose data too, we're really going to open their eyes to menstrual health. So we asked people to collect all of these measurements over the course of 3 months. This gives you a snapshot of the individuals we recruited. So they tended to be young because we're in a college environment. We had people with various gender identities and also various ethnic backgrounds, which also played a role that I might mention later if I have a bit of time. And this is the rough protocol that they followed. So they did collect data over the course of 3 months, but every 2 weeks we had a check-in with them to see how their health tracking process was going, to provide compensation, to figure out the challenges they were having with devices and things like that. So to give you an example of some of the quantitative analysis we've done with the data, We looked at whether that glucose data I mentioned earlier had the relevance that we had seen to the menstrual cycle. So a lot of studies that have linked glucose with the menstrual cycle have done it using standard finger prick glucose tests that you can only do every so often. But by having continuous glucose data and continuous hormone data, we really open the doors to seeing more fine-grained correlations between the two measurements. And without going into too much detail about the exact statistical models that we did, what I'm showing here on the right side is on the horizontal axis, we have progression through the menstrual cycle. So basically from when a person menstruated to the next time a person menstruated, we normalize that cycle so that everyone has the same length so we can compare everything. And on the vertical axis, what I'm showing is how the daily median glucose levels change throughout the menstrual cycle. And what we were able to show is that we have this nice kind of smooth pattern where glucose starts dropping after menstruation, gradually rises again, and then gets back to its baseline value towards the end. So we're able to show that glucose varies with the menstrual cycle along a continuous scale. And the cool thing is that this doesn't just have implications down the road of maybe having a new measurement that we can use to predict the menstrual cycle. We also have the reverse. If someone is diabetic and they also menstruate, then we also have to factor that in when we interpret their glucose data because their menstruation might actually be influencing the glucose levels that they're normally monitoring for, monitoring their diabetes, for example. We've also done similar core analyses looking at the relationships between skin temperature and the menstrual cycle, and we are working on multimodal machine learning models as well. But I do want to highlight some of the qualitative analysis we've done as well. So one of the benefits, one of the nice things that we saw when people had access to this data was that it helped destigmatize menstrual health. I will admit, as a male, it's become a little weird to talk about menstrual health in such a casual way. But even people who menstruate also have similar struggles about talking with menstrual health with others. And there was a particular example that I really was really cool for me to see when we were doing our study. So we had a participant who had lived with a father. The mother wasn't in the picture for whatever reason, and she struggled very often to talk with her dad about menstrual health. It was just uncomfortable to talk with a man about that kind of thing. But because she was participating in our study, she had access to these other kinds of health dimensions, physical activity and sleep. And she felt more comfortable talking about those aspects of her health with her father. So, over the course of our study, she was talking with her father about those aspects of her health. And over time, they gave her a jumping point that made it a little easier for her to talk about her menstrual health rather than jumping into the conversation head on. And this wasn't just an isolated example. We have many cases where people talked with their peers, with parents, with siblings about their menstrual health, and they use other aspects of data as a launching point. But of course, there were many challenges that we encountered during the study. It turns out you can't just give people the data and have them magically learn about their menstrual health. A lot of people in our study struggled to make comparisons both across their own menstrual cycles within their own data and across each other. Whether we liked it or not, it turns out a lot of participants in our study actually found one another and they started comparing their data. And from that, some people saw trends that they thought were interesting that gave them new information about themselves. But there were also cases where people got worried about their data. I'll give an example here about it within individual comparison that someone made. Someone said, I had 4 cycles during the study, and I think the last 2 were kind of similar, but the other 2 were different. And I was like, I don't know what counts as a trend, right? So asking people to look at this continuous waveform data, like the glucose data I showed, for example, earlier, and asking people to make use of that data and to learn more about their menstrual health, it's not really surprising in hindsight, but at the time we were hoping at least people get some information from that data. It turns out there's a lot of work that needs to go into showing this information. I'll give one more example. I don't have it on the screen, but one other example that was particularly interesting to me. It turns out we didn't realize when we first scheduled the study, but part of our study overlapped with Ramadan. So we had a few individuals in our study who also were fasting during a part of our study. And it turns out these individuals all found each other and they were able to see some trends that both lined up and didn't align amongst each other during the study because they were fasting. They were looking at how that fasting affected their glucose levels, their sleep, and inevitably try to extrapolate how that might affect their menstrual health. So this idea of interpersonal comparisons is on the one hand really powerful and really interesting, but I'm sure you can also imagine all of the pitfalls that can happen when people try to make comparisons that maybe don't make sense. So, of course, we've taken the next steps in this research. We didn't just deploy data, these devices and say we're done with it. These are some screenshots from an app we've been developing. I think there's a lot that could be improved with this app, but I'm putting this up here as kind of a call to action of something interesting for people to think about. You can see like the far left screen, for example, looks pretty much like a standard Fitbit kind of app where you can see some high level statistics. In the middle, you can see we have some graphs, which again, you've probably seen oftentimes in other apps. The far right screen, one of the things we've been doing is summarizing the data within particular phases of the menstrual cycle. So this is one example of how we're helping people try to appreciate differences across different phases, across different cycles by looking at variation. And eventually we want to look at different populations. So that concludes my talk. It's a whirlwind tour of some of the research we've been doing. The QR code would take you to a link to see other aspects of the other kinds of projects my lab is doing. And then here's some contact information for myself and my research group as well. So with that, I'll conclude and say thank you.
Wonderful. Thank you. Let's have a virtual round of applause.
Thank you.
And for people in the audience, if you have any questions, please type in your questions in the Q&A box. And I see that we already have at least one question. Alex, do you want me to read it out loud, or do you want to do it?
I can read it out loud.
Thank
Yeah. So the question, and thanks for the question, by the way, it says, could you talk about the challenges you face in continuous health sensing in terms of missing data due to internet connection issues, battery life of the phone, watch or ring, lack of compliance from patients, motion artifacts interfering with PPG, etc. Also, how is missing data handled in the model training? Really good question. I could give you a really long-winded answer. Where to begin? This is inevitably something that we have dealt with with the study that I described, the menstrual health study in particular. People stop wearing the devices. All of the challenges you mentioned are there. In terms of missing data for the statistical models, we've had enough power where we've been able to throw out cases where we have missing measurements and it's been fine. For the machine learning models we're doing right now, we're doing imputation. So we're looking at characteristics of data, and we're looking at trying to find like the next best similar example. For instance, so if we're missing a heart rate measurement, we try to find someone who has similar data other than heart rate, and then we try to fill in the gaps as an example. But ultimately, that depends on finding what the similar cases is. And that's been one of the challenging things we've been trying to wrestle with in the menstrual health space. Because on the one hand, we want to say that everyone has a different menstrual cycle. We want to treat people as individuals rather than saying everyone has the same menstrual cycle. But at the same time, we're also trying to figure out if there's these like phenotypes or similar people that we could kind of group together in order to rely on other training data to help inform our models. So I mean, there's all sorts of answers I could give to your question, but I think that's one example for the missingness. With the lack of compliance, that's one I'll quickly touch on as well. One of the things I've been thinking about really carefully with my research is that giving people devices and saying that's all you're doing for the study, we're not going to give you any value other than just paying you for participating in the study. I think it's very limited. That can only get you so far in research. People don't buy into the research. So with the menstrual health work, again, as an example, we met with people every 2 weeks, not just for the compensation, but to figure out what they were getting out of their data and to make sure that they were involved to get that investment. I think thinking early about when you're setting up your studies, thinking about like, is there some sort of intermediate value? Like, can you build an app where you give people very basic information that gets them involved, even if it's something as simple as like an average heart rate or a step count, just so they feel invested in the data collection process as you're collecting all of your other things like your speech, your glucose, and all that other stuff. I think that will help maybe alleviate some of those issues, but I mean, there's so many challenges associated with those problems. I see a question from Aaron. Any considerations as to the environmental effects with these technologies, e-waste, energy use for AI? Really? Oh, you guys are asking the good questions here. That is an active point of discussion I've definitely heard in my research circle in ubiquitous computing, because On the one hand, we're talking about using commodity devices and using them for these health-related applications. But if I'm saying everyone needs to buy a smartwatch, everyone needs to buy earbuds for these health-related applications, it's generating a lot of waste. That is for sure. And there's a lot of work, research that's been going into batteryless technologies, smart textiles, compostable electronics. So there are some hardware-based solutions that I think are really exciting that I could point to. One of the things I would mention, or one of the stances I've taken on this, is, or I'll rely on something a friend told me that relates. Right now, we could make digital stethoscopes super cheap and super easy to distribute so that everyone could have them, right? The technology is all there. It's just a microphone with a diaphragm and a little bit of processing. But we haven't seen that yet. It's not that, people don't have a digital stethoscope at home lying around. And you could extrapolate this argument to all sorts of medical devices. Blood pressure cuffs, I mentioned earlier, thermometers. I'm not saying people don't have them, but if I were to imagine giving someone all of those devices, that's generating new devices, new batteries, all for a single measurement. One for blood pressure, one for temperature. That is super wasteful. To me, the easiest next best step is, can we use one device for multiple health applications? So, like the earbud, for example, I'm already using earbuds for not just for health, I use it for music, I use it for virtual calls. So, if I could also use this to get some health information, the accuracy may not be as good as, a blood pressure cuff or some other measurement, but I'm not constructing a new device. I'm using something that I'm already using for entertainment and social purposes. Same thing with the smartwatch. If people are already using them for physical activity and we can get some other measurements from it as well, I think streamlining the measurements and the benefits we get from these devices is another way to think of it. The third answer I'll give to this question about the energy use is that when we're building the models for these kinds of devices, thinking about making these models very condensed is very important. So, you can't feasibly do all of the computation on the device. Some of the computation usually needs to go to a cloud, or you have some sort of, large model trained on lots of individuals in the cloud. But if you're streaming all of the data, all of the raw audio, for example, that's a lot of streaming, a lot of battery consumption, and a lot of communication back and forth. So ultimately, it'd be great to be able to do the machine learning on the device so you don't have to spend a lot of battery power doing wireless communication. But at the very least, if you can't do that, then the next question is, can you do some of the computation on the device and then just have the summary features or the summary statistics be used for machine learning in the cloud? So you can offload some of the AI computation work on the device and off the device, hopefully to optimize the battery consumption. So I don't think it's a great answer. It's a very important discussion topic you're bringing up, the environmental implications, but those are some of the thoughts I have on it.
Great, thank you. Can I ask a question?
Yeah, please.
So for the first study that you mentioned for blood pressure,
Yeah,
how long of a measurement do you need to be able to estimate?
not a
And
long
also,
one.
and also, if you continue doing it for longer than you need, will you get better results?
Yeah, great question.
Or does
So
it saturate, basically?
yeah, so we've tried. So first of all, I'll say we've done our study primarily in controlled lab environment, seated condition. We have people do light exercise and people can move their bodies, so that even that will introduce some noise into the signal. So we've been able to show that using as few as like 6 pulses, for example. I pick an arbitrary number like single digit, you can get a decently good measurement, or at least the numbers that you saw on the screen. I'm sure if you were to get more over time, you could get better measurements, but there's definitely going to be a plateau point because you also have to keep in mind blood pressure changes over time. Where I will take your question though, and the reason why I brought up the study design is that ultimately we do want to do continuous monitoring where you could get measurements throughout the day, but there's a lot of noise and a lot of confounds going back to Ali's question, right? So even just like walking while wearing earbuds, that creates body movement, and that body movement gets transduced through the body and creates noise in the earbuds. So one thing that we've been thinking about, and one direction I'm hoping to take this work eventually, is that we can use a momentary sensing paradigm. So rather than trying to estimate blood pressure throughout the day and trying to deal with all the confounds and noise cancellation algorithms and that kind of stuff, can we identify moments in the day when someone's wearing an earbud and it happens to be a relatively static controlled environment? So maybe I stop talking for 10 seconds and my earbuds record then, right? Or I'm walking to the bathroom and sit down, or I don't know. Just those brief moments, can I detect those automatically and get the measurements then, rather than trying to deal with all of the confounds and noise throughout the day? But I think the easiest application that we're thinking right now is like a telehealth scenario. So I'm talking with a doctor on Zoom. I put in the earbuds. The doctor says, "Hey, can you stop talking for 10 seconds so I can get measurements of your heart health?" And then get the measurement then. And I think that's a useful paradigm that we've pretty well fleshed out so far.
Yeah, I think if I remember correctly, the recommendation is to sit still for a little bit before blood pressure
Yeah,
measurement.
yeah. So when you're doing the
Yeah,
blood pressure cuff, a lot of people don't
yeah,
there's like a lot of constraints. So it's
yeah,
you need to not just sit still. You need to have your arm, I think it's like,
yeah,
parallel to your body. You can't have it raised up or
yeah,
down. You aren't supposed to cross your legs whatsoever. There's a lot of constraints. And with the continuous sensing with the earbud, like I'm sure similar things would be in place. It's a bane and a boon, right? You can measure throughout the day, so you can detect trends that we have not been able to detect whatsoever using a standard blood pressure cuff. But there's also going to be tons of noise in the data, right? So there's that trade-off of, do you try to detect the moments exactly where the person is in the ideal conditions for blood pressure estimation? Or do you try to wrestle with this potentially noisy data and hope that the noise averages out and everything works out?
yeah. Yeah. Great, thank you. Are there any remaining questions from the audience? I see that we're 10 minutes past the allotted time, so um, if there are no other questions, I think it's a good time to wrap up and thank our speaker one more time.
Sure. Thank you.
Thank you. And we can stop the recording of the session right now.